Alrighty, students, we're going to start with our materials this evening as an introduction to our PowerPoint tonight, which is slides 83 through 99. We're going to look at anesthesia monitoring. So I want to show a quick video of how does anesthesia work as an introduction before we get into those slides for this evening. So we're going to get started with that right now.
If you've had surgery, you might remember starting to count backwards from 10, 9, 8, and then waking up with the surgery already over before you even got to 5. And it might seem like you were asleep, but you weren't. You were under anesthesia, which is much more complicated. You were unconscious, but you also couldn't move, form memories, or hopefully feel pain. Without being able to block all those processes at once, many surgeries would be way too traumatic to perform. Ancient medical texts from Egypt, Asia, and the Middle East all describe early anesthetics containing things like opium poppy, mandrake fruit, and alcohol. Today, anesthesiologists often combine regional, inhalational, and intravenous agents to get the right balance for a surgery. Regional anesthesia blocks pain signals from a specific part of the body from getting to the brain. Pain and other messages travel through the nervous system as electrical impulses. Regional anesthetics work by setting up an electrical barricade. They bind to the proteins in neurons' cell membranes that let charged particles in and out and lock out positively charged particles. One compound that does this is cocaine, whose pain-killing effects were discovered by accident when an ophthalmology intern got some on his tongue. It's still occasionally used as an anesthetic, but many of the more common regional anesthetics have a similar chemical structure and work the same way. But for major surgeries where you need to be unconscious, you'll want something that acts on the entire nervous system, including the brain. That's what inhalational anesthetics do. In Western medicine, diethyl ether was the first common one. It was best known as a recreational drug until doctors started to realize that people sometimes didn't notice injuries they received under the influence. In the 1840s, they started sedating patients with ether during dental extractions and surgeries. Nitrous oxide became popular in the decades that followed and is still used today, although ether derivatives like sevoflurane are more common. Inhalational anesthesia is usually supplemented with intravenous anesthesia, which was developed in the 1870s. Common intravenous agents include sedatives like propofol, which induce unconsciousness, and opioids like fentanyl, which reduce pain. These general anesthetics also seem to work by affecting electrical signals in the nervous system. Normally, the brain's electrical signals are a chaotic chorus as different parts of the brain communicate with each other. That connectivity keeps you awake and aware. But as someone becomes anesthetized, those signals become calmer and more organized, suggesting that different parts of the brain aren't talking to each other anymore. There's a lot we still don't know about exactly how this happens. Several common anesthetics bind to the GABA-A receptor in the brain's neurons. They hold the gateway open, letting negatively charged particles flow into the cell. Negative charge builds up and acts like a logjam, keeping the neuron from transmitting electrical signals. The nervous system has lots of these gated channels, controlling pathways for movement, memory, and consciousness. Most anesthetics probably act on more than one, and they don't act on just the nervous system. Many anesthetics also affect the heart, lungs, and other vital organs. Just like early anesthetics, which included familiar poisons like hemlock and aconite, modern drugs can have serious side effects. So an anesthesiologist has to mix just the right balance of drugs to create all the features of anesthesia, while carefully monitoring the patient's vital signs and adjusting the drug mixture as needed. Anesthesia is complicated, but figuring out how to use it allowed for the development of new and better surgical techniques. Surgeons could learn how to routinely and safely perform C-sections, reopen blocked arteries, replace damaged livers and kidneys, and many other life-saving operations. And each year, new anesthesia techniques are developed that will ensure more and more patients survive the trauma of surgery?
Alrighty, so that was it for the introduction video for your lecture this evening. With that being said, I'm going to just pause the recording. We're going to go on a quick break before we get started with those slides. All right, students, welcome back from your break. We're going to get started into our PowerPoint for this evening. Again, we're covering slides 83 to 99. Coming out of that introduction video about how anesthesia affects the body, it covered topics like injectable anesthesia versus inhalant anesthesia, different effects, why we might use one over the other, or even in combination with the two. And so that's what we're going to look at. Today, we're going to be looking at a little bit about the equipment that we're using in regards to inhalant anesthetics. So in the last lecture, we were going over the anesthetic machine, the breathing systems. Today, we're going to look at a little bit more about the equipment because we want to look at the flow rate. This is how we're going to be giving the inhalant anesthesia to our patients. We're going to be connecting them, their endotracheal tube, to a non-rebreather or a rebreathing system. So we'll discuss that a little bit later. I have some visuals to show you as well. We'll get into also how to monitor these patients, what to know to look for, how should they be reacting and behaving while they're under anesthesia, what are the vital signs that you're going to be monitoring or different tests that you'll be performing to make sure that they're doing well. Those are the topics that we will be addressing this evening. So starting off, we're going to look at your equipment. And as we're getting into pre-anesthesia, right, that pre-surgery period, we will give antichlorogenics and calming and analgesic agents to the patient. Usually, propofol is very popular in vet med, but like I said before, they can actually use kind of like a cocktail, a mix of they could, again, many different sedative drugs or antichlorogenic drugs that we could use. So we've got, they could do a combination of dextromethorphan, which is very popular, Valium, they could use buprenorphine. Again, propofol could be in that mix. Fentanyl could even be in that mix. And I know that that scares a lot of people even hearing that word because of the recent really just issues and kind of epidemic that's going on with it. But be aware that using it in the medical field, we use it again with that medical purpose, dosed appropriately. And there is many reasons, of course, to put a patient on a strong pain medication, a narcotic, especially as they're going into surgery. They're going under the knife and about to be, cut into and having an operation. So that is needed. We usually will combine some kind of pain, again, some kind of narcotic medication to help with that pain even before surgery, part of this pre-anesthetic medication. And again, it can be a combination. Now, it's not your job to know what medications should you be giving and why. What you need to know is that your doctor, they will determine that. They will determine based off of the animal's age, their size, their breed, their health conditions. They will then decide what is the best medications to use for that patient for the pre-medication and post-medication, of course. So our job as an assistant would be to draw up these medications and administer them to the pet. Usually this is done by an IM injection that's intramuscular, right? So into the muscle. And it takes about 10 to 15 minutes to take effect. The pre-medication will cause short-term general anesthesia. So it helps provide a smooth transition from consciousness to unconsciousness for the induction process. Once the patient loses consciousness, again, this takes about 10 to 15 minutes, we will then provide the endotracheal tube, right? The ET tube. This is the tube that we place in their trachea to provide them an airway for oxygen and anesthetic gas for the procedure. while we're placing that endotracheal tube, there's a few things that we have to look for. We give the pre-anesthetic to set them up for a state that's proper for intubation. So, in order to intubate your patient, to place that ET tube, we have to make sure that there's relaxed jaw muscles. So, we look at the jaw tone. Can you pull down on the jaw? Is that relaxed? We also look at the loss of oral laryngeal reflexes. So, how is um, their laryngeal reflexes, especially with cats? We have to put lidocaine specifically. Lidocaine is a local anesthetic that we will actually we'll just take the medication. It's an injectable medication, but in this instance, we'll pull it up in the syringe, we'll remove the needle, and then we'll essentially just squirt it on top of the larynx, which is the top of the trachea, to relax it. So then we can place that tube. It's very popular to do that in cats because cats are notoriously sensitive, especially for intubation processes. Um, as somebody that worked in cat specialty, I always use lidocaine. I don't even try first without it because cats, again, you're going to be fighting them. You don't want to damage or rip the trachea. It's much easier to just drop the medication up, squirt it right in the back of the throat, give it a few seconds to work and relax that larynx, and then be able to place your tube. Now, you could be placing the tube. You could also just be restraining for the ET tube placement. And more than likely, you're going to be restraining for a while before you're trained on the job on how to place it, if they even want you to do so. Usually, technicians are the ones placing it. The doctors can too. Um, Again, depending on the state that you live in and your clinical setting, they may or may not have you place that endotracheal tube, but you'll be helping with that process. And then once that tube is placed, we get them hooked up to the anesthetic machine. We will apply a um, eye ointment. It's essentially like an artificial tears ointment to their eyes after they're intubated and they're getting moved into surgery. Excuse me. Some patients um, will have their eyes open just a little bit. Most of them do. It's not like they're going to be closed all the way perfectly. So we always give them some type of ophthalmic ointment or artificial tears drops in their eyes to keep them nice and lubricated while they're under anesthesia. And you may have to do it multiple times, especially if the surgery is multiple hours long. Now, maintenance. How do we keep this patient under anesthesia and maintained well during the procedure? In a moment here, we're going to start to look at like the depth of anesthesia and how that varies. With this maintenance, it begins with a good induction process. Once that induction anesthetic dissipates, that injection that we gave, then general inhalation anesthesia begins. So again, we hook them right up to that anesthetic machine. We start to give them oxygen and that anesthetic gas. And then that inhalant anesthesia kind of takes over for that procedure. Now, volatile anesthetics are easier to maintain than injectable anesthetics, meaning the inhalant anesthetics, the anesthetic gas, is so much easier to manipulate than injection. Once you give an injection, it's given. You can't take it away, right? So if you give a full dose, there's no way to kind of back that down when it's an injectable sedation. When you're on anesthesia, all we have to do is turn the dial up or down on the machine, on the vaporizer. Most vaporizers, they go from 0 to 5. 0 meaning nothing is being given. 5 is the highest setting of anesthesia that can be given. So we can adjust that dial at any time on the vaporizer to change the dose of anesthetic that we're giving them. It's very easy to do this. And it's also why, in my opinion, inhalant anesthesia is actually safer than just the injectable sedation. And most people would agree with me with that, especially when patients get older. We tend to not use sedation as often, or because we can quickly place them under inhalant anesthesia, and we can also wake them up a lot quicker than an injectable. Injectable sedation, it's usually last about an hour, sometimes a little bit more than that, and then the patient starts to wake up from it. But it can take them, 8 to 12 hours to really fully come out of that sedative state unless it's a medication where we can give a reversal drug. And there's really only one medication on the market for that. It's dextromethorphan. And then the reversal drug for that is called anisetin. And so that's would be a great option to sedate the patient down and wake them up really quickly. That would be an option as well. But again, it's a little bit more risky versus the inhalant anesthesia. It tends to be really safe. Now, with that being said, as we can adjust the depth, that means that it will vary during the procedure. The inhalant anesthetics that we use in the veterinary field are isoflurane, sevoflurane, and desflurane. That being said, you're mostly going to work with iso or sevoflurane. Sevo is kind of the newest kid on the block. Sevoflurane is a really great inhalant anesthetic. ISO was kind of the one before that, and DES was even before ISO. So with that, I've worked with both ISO and sevoflurane quite a bit in my career. Both of them are great. The plus of going with Sevo, because it is a newer anesthetic drug, is patients tend to go down quicker, wake up faster, and have less side effects, which is great, right? That's really what we ideally would want. That doesn't mean that isoflurane is bad. It's still used very commonly, and it's still a great inhalant anesthetic, but Sevo is a little bit better. Again, just with the recovery times, the induction times, and all of that. That being said, your hospital will have specific machines for those gases. It's not as easy as just buying the different gas and switching it over. You have to have a whole new anesthetic machine to run that specific gas. So there will be specific vaporizers for ISO, and there's a specific vaporizer for SIBO. And you cannot mix those two gases into those vaporizers that are not meant for them. It's not going to it's not going to dose the patient correctly or safely. So something to be aware of is in order for a hospital to upgrade, like to using sevoflurane, they would have to buy a whole new anesthetic machine and equipment that could cost anywhere between $20,000 to $30,000. It is very expensive for medical equipment. So your hospital might not be rushing to get that equipment because again, isoflurane works just great. It works fantastic. It's not that it doesn't. So completely fine whichever route they take or whichever anesthetics they have available. Now, nitrous oxide, that's known as laughing gas, rarely used. We don't use it like really at all in the veterinary field. Of course, they still use it in human medicine, but again, in veterinary medicine, I have personally never used it on a patient for induction purposes. So, that being said, not going to say that you will never see it, but not something that I have seen commonly, or even your lab instructors, I've asked them about it, not something that they've seen very common here either. Now, let's look at some of the advantages of using an inhalant anesthetic. As I was saying before, we can, because of that vaporizer, and we're able to change the concentration on it, it's really easy to control the depth of anesthesia and the speed of how they get to that depth. The inhalant anesthetics will give great muscle relaxation for the patient. Again, once we take them off of the anesthetic gas, once we turn the vaporizer down to zero, we turn it off and or we'll turn it off and then we'll put them on full flow oxygen. Patients wake up rapid. Within 5 minutes, they're going to be up and walking. So it's a really great recovery time, and we are able to deliver high levels of oxygen and the anesthetic agent or the gas through that endotracheal tube. So we know that they're getting oxygen. We know that they're getting good breaths. It kind of guarantees that with using the inhalant anesthesia versus that injectable. But we also have to look at some of the disadvantages of using inhalant anesthetics. And that would be the expense. As I said before, these machines are not cheap, 20 to 30K they can range. And you must have knowledge and skill in order to use these machines and in order to be in surgery, right? It does require training. It requires you to have knowledge about these machines and how to run them and just experience. So it does, we can't just throw somebody right into surgery and expect them to know how to use the machine and monitor and stuff like that. You will have to go through training. And if that's part of your job as a VA, then you will. Some of you may work at clinics where you never do surgery. You're just running rooms or doing urgent care or other things versus you might work at a place that is more heavily involved in surgery, like a surgical center or a specialty center, emergency. So, again, depending on where you are, they will teach you about the anesthetic machines, how to use them, and all of that if they're wanting you in that position. Some jobs won't have you monitor anesthesia. They'll just have you be a sterile assistant or a non-sterile assistant. So again, it just depends. But we do have to have somebody that is trained in order to use this. We also have to be aware toxicity is a thing, right? They can overdose on inhalant anesthesia, just like they can on injectable. We can give them too much of that inhalant, and if a patient overdoses, it absolutely can result in death. There is always risk whenever putting a patient under anesthesia. Keep in mind that the uptake of the inhalation of the anesthetics depends on the ventilation of the patient. So, depending on how good of breaths they're taking, will also depend on how much they're uptaking of this medication. So, making sure that they're taking really good breaths and we're monitoring that reservoir bag is really important. Whoever is monitoring the anesthesia must focus on that patient status only. You will have somebody monitoring anesthesia, and that will be their sole job during the surgical procedure. They're going to be with the patient the entire time. And even though they're going to have them hooked up to an EKG machine or an electrocardiogram, right? They're going to have them hooked up to that. So they'll have access to the heart rate, the rest rate, the temperature, the blood pressure, SpO2 levels. They'll have access to all of that. However, we also take manual vitals. If you are monitoring anesthesia, you will still take manual vitals with a stethoscope. Um, and you can also, of course, watch the patient and their breathing, and you'll be with them. You will not leave the patient's side during the surgical procedure, and you're going to be recording their vitals in a surgical chart every 5 minutes. It says 5 to 10 minutes here. I would never wait 10 minutes. I would always stay with 5. Again, you're going to be sitting there towards the head of the patient, right where the anesthetic machines are and the monitoring machines, the EKG machines are. And so you'll be able to, again, you'll be with them, sitting with them the entire time, continuously monitoring. And that'll be the sole job of that person who is monitoring anesthesia. It's also their job to let the doctor know if something is wrong, which we'll talk about that a little bit later when it comes to vitals and normal versus abnormal, and when should you notify your doctor of that. But before we do, we are going to look at the equipment first, because how we dose our patients will also depend on the systems that we have them connected to. So we have two different systems. We have non-rebreathing and we have rebreathing. And it is what it sounds like. Non-rebreathing systems means that they breathe in fresh oxygen and anesthetic gas with every breath, and they exhale it out. And it does not get recycled through that system. It's a one way in, one way out, which means that your anesthesia has to run high throughout the procedure. Now, a rebreather is when they do rebreathe some of that air. So they're still inhaling in oxygen and that anesthetic agent, but they're exhaling into that same tube, and it does recycle some of that air. So we do have to be aware of, again, the consumption rate. And something that we'll look at for these systems is it heavily will affect the temperature as well. A non-rebreather, a patient that it has a non-rebreather will have more risk of getting a lower temperature than a rebreathing system. Rebreathing systems, if you hold your hand in front of your mouth and you breathe in and out, it gets warm, right? The air circulates and it stays warm. That's what it's going to do in that rebreathing system. So it keeps the patient actually relatively warm versus a non-rebreathing system, right? If you're just breathing in cold air, breathing it out cold air, breathing in that fresh cold air every time, which it's going to be, um, it will drop the body temperature faster. As, as they're under anesthesia and on these drugs, they are unable to regulate their body temperature. So that's something that we mainly focus on while they're under anesthesia is putting them on a heating table, having a water circulating heating pad, or even using sandbags or some other devices to keep them nice and warm, to keep that temperature up because their temperature will drop. Don't worry, I am going to show you guys a visual. I do have a really great video where there is a doctor who goes over the rebreathing versus non-rebreathing, and they'll even show you what these tubes look like and kind of the differences. So don't worry, you will get a visual of that here in just a moment. I do want to cover as well, there are some other systems. So we do have closed systems versus semi-closed systems when we're talking about the rebreathing. So for a rebreather, if we're using that system, it can be closed. And with a closed rebreather, it's got some advantages. It means that, again, they're going to be completely recirculating that air throughout that tube. So there's minimal environmental air pollution. It's economic because you're not going to have to turn the gas up very much. They're recycling some of that. And again, minimal loss of heat and moisture because they've got some of that recycled air. Disadvantages is because there's recycled air, it's harder to control the depth of anesthesia with changing the concentration. So like if you had it on a high dose, if you're lowering it, it's going to take a little bit longer to really affect the patient because they're recycling through some of that air. Now, it also increases the use of the carbon dioxide absorber, which will be working heavily with a non or with a rebreather because it needs to help uh, recycle some of that out as the patient's breathing in. And again, they are on full flow oxygen as well. We also have to closely monitor any patient that's on a rebreathing system, and we're closely monitoring them anyways. That it doesn't mean that you won't on a patient that's on a non-rebreather. But of course, close monitoring whenever you're monitoring the flow rates. And with a rebreather, you will always have high flow rates during induction. You'll want to turn it all the way up to the full dial usually and get them started, and then back it back down once they're in that past that induction stage. Now, there's also rebreathing semi-closed, which means that there is some opening. That being said, with a semi-closed system, there's advantages, there's disadvantages, of course. Advantages of a semi-closed system means that there's less oxygen dilution. If we wanted to give nitrous oxide, this would be the method that we would use, as it would be the safest method. And we do see faster changes in the anesthetic concentration with a semi-closed system versus the closed. Disadvantages, we go back to now with a semi-closed, with that opening, we're going to have a loss of heat and moisture that we didn't have before in a closed system. And it's more expensive. You'll have to use more gas because it's, again, not recycling as much. So with that being said, I want to get shared here a video about rebreathing, non-rebreathing, open, closed, semi-closed systems, kind of differences, and give you those visuals. But in general, before we watch that, the larger the circuit volume, the longer it takes to change the anesthetic concentration. So if you're using um, larger tubing systems, larger rebreathing systems or non-rebreathers, it will need more. It will take longer, especially the rebreathers. It always takes longer. And your rebreathing system size can change too. If you have a 200-pound dog, that breathing system is going to be different than if they're 50 pounds. So, something to keep in mind. And of course, how you change the flow rate is by your vaporizer and having it at the proper setting. We don't want to have them too high because they can get too deep into anesthesia. What happens when they get too deep is that sometimes they can't come out of it. So, very important that we are monitoring them well and adjusting that dose as needed. We can ventilate the patient as well to make sure that we keep them at stable rates when it comes to their SpO2 levels, respiratory levels, all of that. Um, and in this, again, I'm going to be sharing you guys a video here. In this video, they're going to talk about those reservoir bags and how you can give manual breaths and manual breathing as well. So I'm going to get this video shared here. Again, this is going over veterinary anesthetic breathing circuits, what we were just talking about to give you that visual. And they'll also talk about those reservoir bags. Okay, we're going to get started with this video.
Okay, so now what we're going to talk about is switching out our breathing circuits. So far we've been working with a rebreathing circuit. We've been working with the coaxial Bain circuit. The advantage of the coaxial system is that as air or oxygen is exhaled, it warms the incoming fresh oxygen and anesthetic gas, which is found in a tube inside of the exhale tube. The inspiration tube is inside of the exhalation tube. Okay, so as you will learn later on in the course, this also helps reduce something called dead space. The older fashioned version of this was a Y-piece corrugated tubing with a independent exhalation tube and an independent inhalation tube, and what that resulted in is an increase in dead space. So this is an advancement on that design, which reduces dead space and at the same time warms the incoming air. Okay, so but what we want to talk about today is switching this out for a non-rebreathing circuit. So a rebreathing circuit, which is what this is useful in that, as you know, it cuts down on the amount of anesthetic gas that we use, and it also cuts down on the oxygen that we use because it recycles the oxygen. So we get to use it as a low flow system. So by definition, a rebreathing circuit is a low flow system, low flow of oxygen. However, it has its disadvantages. The disadvantages is that it's a big bulky contraption. We've got a canister in there. There's a lot going on. So as a patient, you have to push that much harder to exhale into the system. Okay? You can imagine that's not a big deal for a big golden retriever or a Rottweiler. However, if you are a 4-pound Chihuahua, then breathing against this much resistance might pose a challenge because of the amount of force that you have to breathe with. So for smaller animals and cats, we have an alternative, and that is a non-rebreathing circuit. So this is what the non-rebreathing circuit looks like, and we're going to show you how to connect this. So the first thing you want to do is disconnect your rebreathing circuit. So we go ahead and disconnect it from the system. Okay, we're going to put that aside, and then we're going to come back to our machine and see what we're left with. For the non-rebreathing circuit, we are bypassing this recycling canister. We're not recycling our air, we're bypassing it. We want anesthetic gas and oxygen to go straight to our breathing circuit. So it makes sense that we are going to access the vaporizer outlet. That is the area where fresh oxygen mixes with fresh anesthetic gas and is ready to be breathed by the system. We are going to interrupt the circuit at this point and connect our non-rebreathing circuit right here. Okay, so we've got a couple of connectors on our non-rebreathing circuit. The first one is our gas inlet. This is our gas inlet, and this is the vaporizer outlet. Go ahead and connect that. Okay, you'll notice that our gas inlet is this smaller tube that goes all the way up to our breathing circuit where the patient is going to inhale. Okay. But there's another tube that comes off of this. This is a larger blue corrugated tube, and that tube needs to be connected as well. So that tube is going to connect to our scavenging system. So in this machine, we have a passive scavenging system that is made up of this fair canister. And what we want to do is disconnect the rebreathing circuit from that and connect our non-rebreathing circuit to the canister. We can place the canister back in its little basket behind the machine, or if it's more practical to do so, we can have it lying on the floor on the side where we can work on the pet on the treatment table. Okay? All right, so that is how it works for this machine. We're accessing the outlet. What I want to show you is how it might look on a different machine. So here's another machine where the vaporizer outlet is actually right here. And what would be ideal would be if we go ahead and get access to this, but as you can see, that is a different connection altogether. Instead, this machine is designed to, if we follow this vaporizer outlet, to come out of here into here, and then you have access to the vaporizer outlet on the front of the machine through here. Okay? So as you can see, this easily disconnects, and this is where we would connect our non-rebreathing circuit. What this is here is the connector for the rebreathing circuit and the canister of this machine. What we want to do is interrupt that circuit and connect our machine, our non-rebreathing circuit here. Okay? So that's an interesting variation on the machine. One thing to keep in mind is that when we are connected to our non-rebreathing circuit, we never want to use the O2 flush. So if I use the O2 flush on a non-rebreather, I am sending oxygen into the pet at the 50 psi, which is very lethal and can be very dangerous. So I can demonstrate that right now by pushing on this, and I can actually feel the air coming out of the non-rebreathing circuit. Okay? I don't want that to be going directly into my patients. So what I want to make sure is that, as a rule of thumb, you never use the O2 flush on a non-rebreather. Fortunately, this machine over here has the added feature of a direct access to the vaporizer outlet. So even if I were to not know what I'm doing and push this button, the air is coming out from the back here, from the O2 flush that has been bypassed, and is not coming out of my non-rebreather. I'm not feeling it there at all. Okay, so some machines are set up like this, some are not. As a rule of thumb, never use the O2 flush on a non-rebreathing circuit. Okay? And non-rebreathers are used in smaller animals under usually about 7 kilograms, and rebreathing circuits are used in larger animals that are over 7 kilograms. If you think about it, a larger animal is going to be using more anesthetic gas and more oxygen during a procedure, so that's when you want to have a mechanism to save on the anesthetic gas and the oxygen. And that is another added feature of the rebreathing circuit, is that we get to save some oxygen and anesthetic gas by recycling it. Okay, and with that, we're done with the talk on rebreathing circuits.
All right, so that was it for that video. Again, I do apologize if the quality was a little lagging. That's why I try to have my camera off and things like that. I do want to remind you all that I have this information posted in the module under the video and extra course materials. It's also in these slides. If we go back to slide 83, where we started today, there's 3 different links here, and it's got both of those video links that have already been here shown in the PowerPoint, and again, they're in that section. So you can always go back and rewatch those if for some reason the quality isn't super great. I do apologize for that. It's super clear on my end, so it was good for the recording. But again, you can always go back and find those videos to rewatch them at a later time. Okay, with that being said, let me get it back into these slides. So we were just looking at, again, those anesthetic flow rates with the rebreather, non-rebreather, closed, semi-closed systems. Now we're going to get into anesthetic delivery, uptake, distribution, and elimination, and anesthetic monitoring. So when we're looking at the process of anesthesia, how it enters and exits the body. This is what we're looking at here. We're looking at the delivery, which is giving the anesthetic, right? In this situation, if it's an inhalant anesthetic, they'll be inhaling the anesthesia, and that will then secrete into their pulmonary alveoli, that's in their lungs. Then comes the uptake. There will be movement of these anesthetic molecules, excuse me, from the alveoli into the bloodstream. So it'll start to then go into the bloodstream, which will take us to distribution. This is the movement of the anesthetic through the bloodstream, and it will then, this is systemic circulation here. So it goes through pulmonary circulation, it gets pumped through the heart, it gets oxygenated by the lungs, it's going to uptake this anesthetic, and then it's going to go around that systemic circulation and pump that blood around the body as well as perfusing into the tissues. Now, the elimination portion of this is the reverse of uptake and distribution. So, just as quickly as it goes into those tissues, the medication will move from the tissues back to the blood, back to the lungs, and being exhaled. That's why we see such a fast induction and recovery time, because as soon as we turn off the gas, it only takes them a few minutes to clear out the anesthetic completely from their system. It's a very short-lived medication. Rule of thumb, when altering the anesthetic concentrations, if you need to decrease it or increase it, there is kind of specific ways on how we're going to be doing that. So when you decrease, if you need to turn it down for the patient, they're too deep in anesthesia and we need to back them back down, we will turn up the oxygen. We could even activate the O2 valve and turn the vaporizer down or off completely. When we turn it off, when we're recovering the patient, we turn the gas off completely and then we keep them on oxygen until they start to wake up and we're able to remove that endotracheal tube. If we need to increase it, like they're too light on anesthesia, if a patient's too light, they can start to twitch or move or even react to the sensations of, the incision or having things removed or operating on. So if we need to increase it, then we still turn up the oxygen and we turn up the vaporizer at the same time. We do not activate that O2 flush valve if we're trying to increase. Once the patient's at a stable rate, then we can back the oxygen back down a little bit and keep the vaporizer at that setting if they're settling well. Knowing whether you need to decrease or increase the concentration ties into your monitoring. Comprehensive monitoring of your equipment and monitoring of the anesthetic depth. You always want to make sure that your anesthetic equipment is working well. There's no leaks or issues, that it's all functioning correctly. You will do quality control checks before every single surgery to make sure that everything is in working order. And through that comprehensive monitoring, you also need to monitor, again, the patient. You're going to be evaluating their central nervous system, their pulmonary function, their cardiovascular function, and rule of thumb in surgery is to expect the unexpected. And what that means is that anything can happen at any time. Just because you have, several spay procedures scheduled, and they're all young, healthy dogs and cats, doesn't mean that every procedure is going to go smoothly and act the same way. You could have to have your patient on a much stronger dose of anesthesia versus your next patient could be extremely sensitive and you have to have them very light. It just depends on, again, things like the patient's age, the species, the breed, the medical conditions if they have pre-existing. We also need to monitor their anesthetic depth. So, how deep are they into anesthesia? And this is subjective. We're going to look at a few different things. We're going to look at muscle tone. We're going to look at the ocular reflexes. So, do they have blinking reflex or any eye reflex? Is their heart and respiratory rates normal? How is their blood pressure? Also, temperature. And remember that monitoring anesthesia is not a steady state. They can need more anesthetic as they're being put under surgical stimulation. So the patient could go under anesthesia really easily, but then as soon as the doctor takes their scalpel and goes in for that incision, they could start to wake up or again show signs that they're feeling pain, which is, any twitching or moving. You might have to adjust the dose immediately. And same thing if, if they're doing an orthopedic procedure and they're, you know, placing screws and plates and all of that in the joints, that can be extremely painful, as you can imagine. So that type of procedure will probably require a much stronger dose of anesthesia to keep the patient at a good depth, to control, again, them having any sense of feeling or sensation during a more invasive procedure. But depth is dose dependent, right? We can always change the dosing. But one thing to remember is, again, we need to make sure that we're not getting them too deep into anesthesia. If a patient goes too deep, there is risk that we can't bring them back. That we're always running that risk when they're in it, when they're going under anesthesia or they're being sedated, is that it could be too much. They could have an anesthetic reaction to the drugs that we're using. So those are things to keep in mind. Not every patient is the same. Every single patient will be different. They could be happy, healthy, totally fine, and have a medical emergency happen in the surgery. There's no way to say that it's going to go well. And the doctor and yourself, you could do everything right and things can still go wrong. So do keep that in mind. In our next subject, we'll get into kind of monitoring the patient and what to look for. One thing that I want you to keep in mind is that you should always notify the doctor if anything changes, right? If there's any changes in their vital signs, any changes in their monitoring equipment that can cause any type of concern, notifying your doctor immediately is the best thing that you can do. You are not expected to know what to do. If a patient's blood pressure gets low or high, or if there's issues with the heart rate, they're not going to expect you to know what to do. With time and experience, you might know kind of what the treatment will be. But your job for monitoring anesthesia is to tell the doctor when there's concerns and then follow the doctor's orders, right? The doctor's the only one that can diagnose, prescribe medications, and give the order to give those medications. So again, whenever we see that slight variation starting, our patients starting to not do well, there's a variation in their vitals, letting them know, and then they will then instruct you what to do moving forward. Alrighty, so that being said, let me check our time here. We're right at 7:45. Okay, so we're gonna go into our next break. And when we come back from the break, I will be showing you all a video about anesthetic monitoring, kind of the depths and a little bit more tips and tricks on how to really know. There's we're gonna go over the planes and depths, and they're gonna go over 5 different ones about, again, kind of those increasing levels of the depths and what your patient will demonstrate when they're at each level. Okay, so with that being said, I'm just going to pause this recording. Alrighty, students, welcome back from your break. We're going to get back into your PowerPoint for this evening. Before we went on our break, we were looking at monitoring the anesthetic depth. Getting into that subject, estimating the anesthetic depth, I'm going to show you a video here in a moment that's going to go over the stages of anesthesia and looking into, again, what does, those different stages look like? What are the symptoms that you'll see in your patient? And how do you know if you're at a good spot? Again, main things that we look at is, of course, we're going to look at the vital signs. We're also going to look at things like jaw tone, eye reflexes, and those things will diminish as the depth increases. So as they get deeper into anesthesia, their muscles will relax, their jaw tone relaxes, their reflexes stop. That being said, if they have a direct response to surgical stimulation, right? Like the doctor is starting to do some kind of cut or maneuver in the surgery and they start to move a little bit or have a reaction to it, that means the patient's too light in anesthesia and we need to increase the rate and depth of that inhalant to get them in a deeper stage. So again, I'm going to share here a video about the stages of anesthesia. We'll watch through this video and then we'll come back to our slides. We only have a few more slides left, and we're going to then look at the different vital signs and testing that we use to also help us with monitoring. Alrighty, so we'll get into this video here now.
Hello everybody, this is Tyler and I am here to talk about the stages of anesthesia. This is going to be a basic video. We're not going to get into the intricacies of anesthesia. I just want to give a good outline of what we're talking about when we describe the phases and the stages of anesthesia. So based on Goodall's classification, there are different phases of anesthesia. This is going to include our induction, so putting the patient to sleep, maintenance, so keeping the patient asleep, and emergence, which is going to be waking the patient up after anesthesia. So this is going to be our phases. Now there's different stages of anesthesia that we can be talked about. These can be superimposed upon our different stages. So we have stage 1, we have stage 2, stage 3, 4, and 5, and then we're going to emerge in the reverse order, but we'll get to that later. So what do I mean when we're talking about the different stages of anesthesia? So again, I said we have induction, so putting the patient asleep. I've been told by my mentor, Dr. Duong, he was the one that introduced me to the concept of anesthesia is just like flying an airplane. The takeoff and the landing are always a little hairy, but the maintenance is, tends to be more autopilot mode, as long as everything goes according to plan. So here, we're going to be putting the patient to sleep. We need to induce the patient. When we induce a patient, they're going to go through the different stages of anesthesia. So we're going to give a medication or a combination of medications, and they're going to transverse from stage 1 to stage 2 to stage 3, and hopefully not to 4 and 5, and then they'll come out in reverse order. So what do I mean when I say stage 1? Stage 1 is going to be the time between giving an induction agent, so giving an agent or a drug, and the time of loss of consciousness. So the patient's going to be awake when you initially give, let's say, propofol as our induction agent. So we're going to give the propofol. They're going to be still awake until it hits their system. Once the dose is large enough, it's going to affect their brain. They're going to lose consciousness. So this is stage 1 of anesthesia. So it's the time when they're awake after you've given the propofol agent to the time that they've lost consciousness. Now, once they lose consciousness, loss of consciousness, then we're going to enter stage 2 of anesthesia. This is called the hyperexcitable state. So I'm just going to write that down here. So the hyperexcitable state, typically, it's pretty short in induction. So it's the time between loss of consciousness until the patient regains autonomic stability. Now, by saying they are going to regain autonomic stability means they're going to lose it at some point. By the time that they lose consciousness, during stage 2, the patient is going to be hyperexcitable. The body loses its ability to regulate the autonomic system as well as it would without anesthesia, meaning the body will partially lose the ability to maintain temperature, blood pressure, The breathing becomes irregular. They may have GI issues such as vomiting. They're going to lose their protective airway reflexes. Now, like I said, during induction, stage 2 is going to go rather quickly. You're not going to see the temperature swing. You're not going to see the blood pressure go all over the place. You're not going to see their breathing be irregular for very long. It's going to be a pretty short amount of time because stage 2 is fairly short. They're hyper excitable because they're going to decrease autonomic stability. All right, moving on. Once we've regained our autonomic stability, so we're going to have normal autonomics. Now, stage 3 is the stage that is desirable. This is what general anesthesia wants. We want the patient to be in stage 3 because it means they have normal autonomics. Stage 3 is going to transverse our normal range until we start seeing a drug overdose. So this is surgical anesthesia. Our ultimate goal is stage 3 for general anesthesia. You may see a little bit of respiratory depression, but in general, stage 3 is going to be broken down into 4 different planes. So we have different phases, which is the induction, the maintenance, and the emergence. We have different stages, which depend on the patient's stage of anesthesia. Stage 1, 2, and 3 we've kind of already covered. And now we've got 4 planes. So the 4 planes of stage 3. Plane 1, we're going to have eye rolling initially, and then that's going to become fixed. So you're going to see the eyes moving about, rolling back in the head, and then eventually they'll become fixed. You're also going to have loss of corneal and laryngeal reflexes. Sorry, I can't write and talk at the same time. Next, you're going to see the pupils dilate. And also see a loss of light reflex. And then lastly, during our 4th plane of stage 3, you're going to have intercostal paralysis. And you'll see short, shallow abdominal respirations. Now, stage 4 and stage 5 are not what we want. Stage 4 and stage 5 means you've given too much. It's an overdose of your anesthetic agent. So stage 4 is going to be the first signs of overdose. Here you're going to see your decreased breathing. We're going to see autonomic instability reemerge. Stability. Can't spell. Autonomic instability. And then stage 5 is going to be where your heart stops. So stage 4 is going to be an overdose, but our heart is still maintaining its perfusion. We're still maintaining adequate cardiac output. Stage 5 is where our heart is going to stop. That means you have gone way too far. Now, the emergence. So there's going to be 5 stages of anesthesia. We covered 1, 2, 3, all 4 planes of stage 3, 4, and 5. So now how do we emerge from anesthesia? Assuming we didn't go into stage 4 and 5, which is drug overdose, that's a lot of drug. We're going to start out in our surgical anesthesia stage, which is stage 3. So here, we're going to need to emerge. Our patient is in stage 3, they're asleep during the operation. The surgeon is talking to you and they're saying, we're giving you the 15-minute heads up. We're just closing up the skin right now. You're going to want to bring the patient about to their senses again. Like I said earlier, the induction phase of anesthesia is going to transverse stage 2 fairly quickly. However, when we emerge, stage 2 is going to last a little bit longer. So the patient's in surgical anesthesia. We're going to need to bring them from stage 3 through stage two. Stage two is going to last a little bit longer. Remember, that's our hyperexcitable state. That's where our autonomics are all out of whack. We may see this a little more. The patient may begin to squirm, thrash their arms about, their blood pressure may tank or go higher, their breathing becomes irregular, etc., etc. It's going to last a little bit longer. It's going to be more noticeable during the emergence. And lastly, we'll get to stage one. The patient starts to settle down, their autonomics can get controlled. Finally, they become awake. So remember, reverse order for emergence. Now, here are my references for this. Hope you enjoyed.
Okay, so that was the last video that I was going to show today about the stages of anesthesia. So now we're going to get back into our slides to get into monitoring their physiologic conditions. And again, this will tie into also helping you with determining that anesthetic depth. So we'll get back into these slides. We only have a few more left before we're completed with the section for today. So what are you going to be monitoring when it comes to your patient? So you're going to be looking at things, your main vital sign that you're looking at is respiratory function, right? They're under inhalant anesthesia. They must be inhaling and exhaling properly to receive the medication. We need to make sure, of course, that we're using equipment to help us determine that respiratory function. So more than likely, you'll be using a pulse oximeter or a pulse ox, some kind of rate monitor, usually like an EKG machine, electrocardiogram, to help you monitor your patient. You might also use a ventilometer for your oxygen, as well as things like the blood gas machine. This is a diagnostic machine that we used to determine the anesthetic gas concentration levels in the blood. So we look at things like oxygen levels and where they're at and making sure that the patient is doing well under anesthesia. You would probably only use a blood gas machine in the instance of a long procedure. And I'm talking about 2 hours or longer. Which if you work in, for example, I worked in large animal medicine and colic surgery on horses could be 5 hours long. It could be a very long surgery depending on what's going on and what we need to correct. Orthopedic procedures, those also can be lengthy. So you may or may not. Again, if you work in surgery at those surgical centers, you're more than likely going to see a blood gas. But if you work at general practice, your surgeries are under 2 hours, there's really no reason to run that type of diagnostic testing. Now, when we look at respiratory function, it's going to indicate that there's adequate oxygenation of the blood and carbon dioxide removal. And again, there's tests that we can run to also determine that. That goes back to, again, our blood gas machine, which will run the arterial blood gases. We can look at just plainly the respiratory rate and monitoring. We can also get into monitoring the breathing patterns and even doing other blood tests like hemoglobin saturations. Again, those are all things that we can use. When it comes to monitoring, though, it's really just making sure that they're hooked up to their monitoring equipment and doing your manual retrieval of those vital signs, taking that stethoscope, putting it to the patient, having a hand on them, and really closely monitoring them. Those extra tests and tools are great, but they're not necessary. We don't have to have them to do good anesthesia and have good monitoring practices. I've worked at clinics that were definitely lower funded than others, like in shelter situations where we didn't have all that fancy equipment. We just had our monitoring and our EKGs. That doesn't mean that we weren't able to do surgeries and do them well. Again, you just kind of got to work with what is available where you're at. Now, we're also going to be using things like hearing, vision, and touch. You yourself will want to listen to the patient, watch the patient, and touch the patient. Make sure using all of these to monitor their respiratory system. If I can, if they're not operating on the thoracic region, I will have my hand underneath the drape and on their rib cage the entire time because I like to feel that they're breathing the entire time. If they're operating in the thoracic region, that's not an option. And I can use there's an esophageal stethoscope that goes down the esophagus um, that I can use to hear the breath and lung sounds. Again, if a standard stethoscope's not an option, they're operating in that thoracic, that chest region, that would then be the alternative. And you don't need to invest in an esophageal stethoscope. Your hospital will have one available. I do recommend investing in a good standard stethoscope. Again, Littman is one of my favorite brands if you were looking at purchasing one. Um, but when it comes to esophageal ones, it's a very specific type of model, and they will have one available at your practice, especially if they're going to do surgeries in that kind of region. They're going to have that available. And of course, you can always just watch your patient. When it comes to respiratory, if I'm doing a respiratory rate on a patient that came in for a physical exam, or even a patient that's in the hospital, I can just watch them and observe their chest wall rising and falling, right? Observing that inhalation and exhalation. In anesthesia monitoring, I can also observe the reservoir bag, right? That reservoir bag that's going to be, it should be also decompressing and then also then increasing its volume as the patient's breathing in and out. And if we don't see the bag moving very much or it's filled with air and not moving at all, again, that is showing us that our patient is not taking adequate breaths. So there's many things that we can monitor just with that patient. We also, when it comes to respiratory function, mucous membranes can be a huge telltale of how the patient is doing with that inhalant anesthesia. You want to observe the mucous membranes, right? The gums, the color of the gums, but you also want to observe the color at the surgical site. How does the skin look? What is the color of the blood? Those things will also determine, again, how they're doing under that anesthesia. And we'll get into, I do have a visual here in a slide to show you mucous membrane colors and kind of differences and what to look for. We're also monitoring things like cardiovascular function, right? We're also looking at the heart rate. We need to make sure that the heart is beating and it's steady and it's stable. So we're going to be listening to the heart rate, the heart sounds, also the pulse quality. How strong is the pulse? Is the rate constant and steady? We may also look at arterial blood pressure. They should have a blood pressure cuff on that's usually connected to your EKG machine, and we continually run blood pressure. Anesthesia can heavily affect blood pressure, so that's a very important vital that we have to be monitoring. Now, we're also going to be looking at, of course, as we just said, the mucous membrane color, so the colors of the gums. We're also going to be doing capillary refill time, seeing how fast those capillaries refill, and hooking them up to that electrocardiogram machine. And that EKG or electrocardiogram machine, again, that monitors heart rate, resp rate, blood pressure. Most machines have a temperature probe. They also monitor SpO2 levels. So it's really great tool to use if you have that available. Most hospital, and that's standard in hospitals, is to have electrocardiography on patients that are under anesthesia. Optional for patients that are sedated, but it's a great tool to use if you have it available. Now, another condition that we're going to be monitoring is body temperature. As stated before, patients lose the ability to regulate their body temperature when they're under anesthesia. And we need to make sure that we keep them at a good, steady, and stable temperature. Usually anywhere between 99 to 102 is normal in our dogs and cats. And so we don't want it to be dropping down. It's normal to see it get it down to 98 or 97, but no lower than that. We use things like heated tables, water circulating heating pads, We can even heat up fluid bags or sandbags to keep the patient warm. Body temperature will be an indicator of any central nervous system and cardiovascular function. So when we see it start to drop, that also means that the body is struggling while it's under anesthesia. We like to use the esophageal thermometer. That's going to be the temperature probe that's connected to your EKG machine. But if that's not an option, like if you're doing if the patient's going in for a dental procedure, they're, operating in the mouth, that's not going to be ideal. So we can use a rectal thermometer if needed. We would just have to keep pressing and turning it on and taking the temperature every 5 minutes. The temperature probe will continuously monitor the temperature. So again, if you're using that rectal thermometer, you would just then have to manually start the thermometer every few minutes to monitor that temperature. Last slide for this section. This is just showing some examples of different mucous membrane color. So we know that normal, healthy mucous membrane is going to be a pink or a light pink color. And that's also what the colors of the tissues should be, if you were looking at like the incision as well. What you're looking at here are abnormal mucous membrane colors. And there's actually one color that's not on here, that I will mention as well. The first image that you see on the left is icteric. This means it's essentially jaundice. It's like a yellow tinge to the skin. It can even cause that yellow tinge into the white of the eyes. It can cause dark urine, itchiness. It's usually caused by a buildup of bilirubin. And it's really going to be indicative of some kind of problem with the liver. It could be inflamed, there could be some kind of obstructed bile duct, or underlying conditions. When we see pale mucous membranes, this is usually anemia. There's usually some type of lack of blood or blood loss. So if the patient came in due to traumatic injury, again, and then having blood loss with those injuries, it's normal to see those pale mucous membrane color when there's been adequate blood loss. That means this patient needs a transfusion ASAP. If the patient hasn't gone through a traumatic injury and they still have pale mucous membranes, it could mean that there's internal bleeding. And usually it means that there was an internal mass that ruptured. And so we would need to take x-rays immediately to determine that. The last picture you see here, this brick red mucous membrane color, brick red, or just that dark red, indicates that there is severe dehydration. It could also be endotoxemia, which is essentially related to poisoning from toxic plants or toxic substances. Now, there is another color that's not listed here, but the gums can become gray or blue, kind of blue, purple, gray color. That would indicate shock, that the patient's going into shock and that the central nervous system, the circulatory system is starting to revert. And it's not perfusing to all of the tissues, and it's really just doing pulmonary circulation, which is keeping the main vital organs alive. It's not going through systemic. And that's a very serious condition that has to be treated right away. All of these that you see here would indicate a very serious condition that needs to have immediate attention. And again, if you ever see abnormal vitals, telling the doctor right away is essential because they will then give you the orders and tell you what you need to do to help correct this and stabilize the pet. And remember, you're there to monitor. It does not mean that you caused that or that it was your fault that the patient's vitals are being weird or changing. Patients can have reactions to anesthesia, and it happens all the time. So keep that in mind. You're not going to get in trouble for telling the doctor that the patient's crashing and not doing well. You're supposed to do that. That's your job. And then you're also supposed to do the treatments that the doctor is telling you to do to help get the patient back to where they need to be. So again, communication's super important, especially whenever you are monitoring anesthesia, and you are monitoring their vital signs as well. All right, students, with that being said, that is the end of our section today. We're right at slide 99. So I am going to stop the recording now.